Good evening and welcome everybody to session 2. So as indicated, session 2 is more about the clinical practices, the movement of vaccine storage and use of the vaccine, and also reporting of adverse events. Welcome to this session, and we look forward to present to you tonight. Each section will be presented by different presenters, and I'll introduce them before each of the sections. At the end, there will be a list of all of the presenters so that if you wanted to contact them afterwards, you can go ahead and do that. So the first presentation is effective vaccine management, cold chain, logistics, and distribution of COVID-19 vaccines. The presenters for this section will be Mr. Rob Botha, Mr. Stuart Murray. It's either Mpo or Monsonique that will be presenting on SVS, and lastly, I will present on vaccine wastage. Rob, when you're ready, you can start. Thanks.
Hi, good evening, colleagues. This is Stuart. A warm welcome to you on this cold, almost winter's evening. The control tower team is responsible for supply chain specific inventory planning across the vaccine program, from source, that being the manufacturer, through to the primary vaccination delivery sites. The control tower team works closely in conjunction with the service delivery teams across both public and private sectors to ensure timeliest vaccine supply and availability. The team also manages and oversees the vaccine distributors. This is done by conducting monthly performance reviews with the 3 vaccine distributors, addressing any service issues that may arise, putting corrective and preventive measures in place where necessary. The team also works closely with ancillary suppliers, sharing vaccine forecasts with them, thus allowing the ancillary suppliers to better manage their procurement and ensuring improved availability of ancillary items. Lastly, the control tower team coordinates the flow of purchase order requests from both public and private sectors through the 3 distributors. We as the control tower team are responsible for ensuring equitable access to both brands of the vaccine through both public and private sectors. This is achieved by managing the timely flow of orders to the distributors and by coordinating and scheduling deliveries to the primary vaccination sites. The team is also accountable for sharing inventory availability data with all stakeholders across both sectors, thus ensuring availability of information for better decision-making within all levels of the vaccination program. Next slide, please. Calculating your site's vaccine requirement is crucial to both ensuring enough doses are available to meet the demand and ensuring you do not sit with excess stocks expiring due to both storage temperature requirements and or a forward look into your vaccine demand. This is done by looking at your area-specific target population and ensuring your scheduling numbers. And scheduling numbers, this I mean your EVDS scheduling is a view of people who have booked a visit to your site using the EVDS app, or if you're in the private sector, your company-specific booking application that you might have. Then don't forget to take into account how many walk-ins your site allows or can manage, the brands of vaccine you're administering, and looking at doses. Pfizer has 6 doses, of course, and J&J 5 doses per vial. Then lastly, calculate in a factor for wastage. And please don't forget to consider your stock on hand and any outstanding deliveries that you're still expecting in. This allows you to calculate your order and not just guess your order requisition quantity. Next slide, please. NHPDS was developed to collate vaccine purchase orders from public sites and via an interface with ordering platforms in the private sector for the control tower team to seamlessly manage the ordering process. Please don't forget the cutoff times is Wednesday evenings at 10 o'clock, 2200 hours. Orders are presented to the distributors the following morning, so please ensure that your orders are placed timelessly. And then the distributors start their scheduling and picking planning on the Thursday morning. Deliveries typically take place between Tuesdays and Fridays. The reason why Tuesdays and not Mondays is because distributors do not pick and pack over the weekend. The control tower team shares via email the planned delivery dates with both the provinces and private sector groups on Monday mornings. If you're an ICPA member, it's shared with ICPA and they in turn share it with you. alerting you of when to expect your delivery. Next slide, please. The private sector can place their orders through OrderWise, OrderDirect, Surgicom, or Xprocure. These are the 4 leading ordering platforms used by approximately 98% of all pharmacies and all hospitals to place their orders with their pharmaceutical wholesalers. You should all be familiar how to use the system. And for the private sector sites who don't subscribe to one of these 4 ordering platforms, OrderWise kindly developed and donated a free order platform called OrderCo for the private sector to place their vaccine orders, so they can all be done electronically. The public sector has a direct log on into NHPDS, a secure web platform to place their vaccine orders. On Thursday mornings, what do? The control tower team reviews all the orders received, ensuring FIFA, that's first expiry, first out, then collates orders for each of the distributors and sends the distributors their specific order set. As mentioned, we have 3 distributors, 2 for Pfizer, which is DSD and Biovac, and 2 for Johnson & Johnson, which is Kawari and Biovac. The reason why we have 2 for each is to ensure that in case of any disaster, we are fully recovered. Each has a full set of each other's of their customer master to ensure that it's seamless switchover that our team coordinates in case there is a fridge failure or any type of incident that we need to overcome. Thank you all for your time and continued cooperation with the control tower team. I'd like to now hand over to Rob Werter, who will continue. Thanks very much.
Thank you, Stuart, and good evening to everybody. I'll take you through the logistics around the vaccines. Firstly, from a receiving process, on receipt, you will receive your package, which will have a temperature recording device. Now, each of the 3 distributors has different temperature recording devices, and the specifics around those can be found on the Knowledge Hub under each of those, so please be familiar with that. What we have tried to do is allocate a specific supplier to a particular site so that you should receive on a regular basis from the same distributor. However, there may be situations due to first expiry, first out, or other situations where we may have to switch between the distributors. So please be aware of those when you do receive them. So on receipt, where possible, if the device allows to download and save the temperature record for future use, particularly if there's ever a requirement for redistribution at a later stage, usually the receiving site will request that you supply them with the temperature records for that particular shipment. Also then record the temperature on the invoice. So this is the temperature at which it was indicated when you received the shipment, and check that the quantity of the vaccine that you have received aligns with the order as well as with the invoice. It's then important at this point to pack it away immediately. Obviously, the vaccines are temperature sensitive, some more than others, so the sooner you can pack it away, the better. Then please sign the invoice and return the signed and stamped copy to the driver. And if you do detect any discrepancies, be it a temperature deviation or be it a quantity deviation, please do take this up with the distributor, and there will be a process that is defined in the Knowledge Hub as to how to manage that. Thank you. Next slide. Now, as we are aware, we are using 2 vaccines in the country. That is the COVID-19 vaccine from Janssen, or the J&J vaccine, and the Pfizer or Comirnaty vaccine. When these arrive in the country, they are brought in at the coldest possible temperature that each of those vaccines may be stored. So for the J&J or Janssen vaccine, that is -20, and for the Pfizer or Comirnaty vaccine, that is -70. So these are brought into the country at those temperatures, and they are stored in the central warehouse of the vaccine distributors' warehouses at those temperatures. Next slide, please. So we have multiple situations where the primary vaccination site may either have -20 or 2 to 8 temperature storage conditions, or there are even instances where there are -70 freezers in some of the provinces now. We will look at each of the 2 scenarios being the -20 and the 2 to 8 storage. So for the Janssen vaccine, when you receive the doses at a site that has -20, you can store that at -20 for the duration of the expiry date of that particular batch at -20. Once you've moved it, in other words, once it's thawed to 2 to 8 degrees, you can then store it for 11 months at 2 to 8 degrees. This was changed recently. It was previously 4.5 months or 135 days. It has now been extended to 11 months. So any site that has 2 to 8 degrees storage can store the J&J Janssen vaccine for up to 11 months at 2 to 8 degrees, which significantly assists to improve the cold chain and the ability to store for a longer period without the risk of expiry of those vaccines. If the site has -20 storage and is receiving the Comirnaty or Pfizer vaccine, you will receive this from the central storage site at -70 degrees, and then it can be moved to -20. It can be stored at this temperature for a maximum of 14 days, and then it needs to be moved to the 2 to 8 degrees, where it can be stored for up to 31 days at 2 to 8 degrees. And thereafter, it should be discarded of using the correct procedures. Please do note that, and I'll touch on it a little bit later, but as of this morning, a new circular was distributed, which has extended the expiry date that the Comirnaty or Pfizer vaccine may, the shelf life, from 9 to 12 months from the date of manufacture. And I'll touch on that a little bit later in the next slides. Thank you. Next slide. So if the site has 2 to 8 degrees storage, as I mentioned, for the J&J or Janssen, it can be stored at this for 11 months. And for the Pfizer or Comirnaty vaccines, irrespective of the temperature at which it was received, it may be stored at 2 to 8 degrees for a maximum of 1 month. Next slide, please. Okay, so when we are doing redistribution of vaccines from the primary vaccination storage site, there's a number of items that need to be taken place or considered when we're doing this redistribution. Each of the vaccines obviously has its own unique requirements, and we need to be sensitive to this. At all times, we should be considering the quality, safety, and efficacy of the product, and there are SOPs that are on the site that will assist with this. So some of the items that do need to be considered is the duration of the journey and the transport conditions and the temperature profiles of the routes, as well as the temperature requirements of the vaccine. So things that need to be taken into account, for example, in redistribution, is that the Pfizer vaccine, for example, is light sensitive, and therefore it should not be exposed to extended periods of light, as well as obviously the temperature. Also, if you are moving it at 2 to 8 degrees, it should be done for no more than 12 hours, as continuous shaking of the vaccine for an extended period of time is also not ideal. So these are some of the items that need to be taken into account when redistributing. The correct type of coolant and packaging material, as well as the correct quantity of coolant, needs to be taken into place, and validated passive containers that are approved by the WHO should be used, as well as continuous monitoring devices for the duration of the journey. It is not advised to use gel packs, as these tend to lower the temperature beyond the 2 to 8 degrees, which increases the risk of freezing, and neither of these vaccines may be refrozen after they have actually been defrosted to the 2 to 8 degrees. During the distribution, as we said, there will be continuous temperature monitoring devices, and these records should be kept after the vaccine has been receipted. We have noted that due to short expiries, there is often a requirement to redistribute vaccines to avoid expired stock. And as I mentioned before, the receiving site will request the temperature records just to make sure that the product that they are receiving has been kept at the correct storage temperature. And then obviously the vaccine properties should be considered. The heat and freeze sensitivity of each vaccine needs to be taken into account. Next slide, please. So just to recap on the different temperatures at which the Pfizer Comirnaty vaccine may be stored. So it can be stored at -70 degrees up to the maximum expiry date of the product. Now, it does state here that this is the expiry date on the carton. As I have indicated, we have already had 2 extensions on the expiry date from date of manufacture, which was originally 6 months, then it was 9 months, and as of this morning, we have now received SAHPRA approval for 12 months. So the date that appears on the packaging may not necessarily be the expiry date. Please make sure that all sites have a copy of the circular that was distributed this morning so that they do know what the expiry date is. We have had complaints from the media that people receiving vaccines are complaining that they're receiving expired stock. This is because what appears on the packaging versus what has now been approved from SAHPRA is different. So please make sure that all sites are prepared with the circular and can answer a question from the public if anybody does ask it. Once it's been moved from the -70, it can either be moved to -20 for a maximum of 14 days. Thereafter, it can be moved to 2 to 8 degrees for 31 days. Otherwise, it may then be moved from -70 directly to 2 to 8 degrees, but again, only 31 days at this particular temperature. So if you have both -20 as well as 2 to 8, it's a maximum of 45 days. Otherwise, if you only have 2 to 8 degrees, it's a maximum of 31 days. Please make sure that as it's moving from one temperature to the other, that the new expiry date is recorded in a way that is legible, and that the original expiry date is removed and unreadable so that there is no confusion from anybody that is actually looking at the vaccines where there's a change in staff from one shift to another. Next slide, please. For the Janssen vaccine, as I've mentioned, this is stored centrally at -20 and may be stored at this temperature for the duration up to the expiry date of the product. This expiry date can actually be found on the website, or you can scan the code, which will take you to the website where you'll be able to determine what the expiry date is of that particular product. And then it may be stored at 2 to 8 degrees within the overall temperature for up to 11 months, after which it should be discarded. Again, as it moves from one temperature range to the next, please make sure that the temperature, that the expiry date is updated and that the previous is no longer legible. Thank you. I'll now hand over to Yash.
Thank you very much, Rob. So I'll be taking you through some SVS COVID-19 basic principles. The first important thing to note is that only sites storing the COVID-19 vaccines overnight must use the COVID-19 instance of SVS. And when they are using this COVID-19 instance of SVS, they are to report daily, and that's before 11:45, and that's for all COVID-19 vaccines. And weekly reporting must be completed for all ancillary items and diluents before Friday at 11:45 in the evening. Capturing fields, each time data is submitted, all capturing fields must be recorded, so don't leave any out. And all data must be recorded as vials and not doses. Very important to remember. And also very important is that only the last update per item for the day will be recognized as the update for the day. So don't report multiple times in one day. Looking at the left-hand side. So successful syncing after updates is required for sites to reflect as compliant. So it's imperative that sites do sync. All COVID-19 vaccines on the site's SVS formulary must be reported on, including those where stock is not held at the time. So even if you're out of stock, does not mean you don't report for that specific vaccine. For skipped reporting days, end users should update data for all the days missed on the day of capture. So that will be the days you've missed plus the day that you're capturing, and you just add them together. And this will ensure that stock is always balancing and for what it's received from the supplier or the distributor. The current stock level I'll touch on a bit later in the slides. So also at the bottom, it's important to note that SVS is not a transactional system. So the user should not use it to update multiple times in a day for every transaction, for instance, issues, receipts, losses, or etc. During the course of the day. All partially used vials cannot be used after 6 hours of the vial's first puncture and therefore considered as issued and should be recorded under stock issued. Next slide, please, Marion. Thank you. So on SVS devices, these are the data capturing fields that the user would have to input. The first one is the current stock level. For vaccines, the vial count in the freezer or refrigerator at the end of the reporting cycle, as well as your diluents and ancillaries. So the individual stock item count in the bulk storage area at the end of the reporting cycle weekly, as well as the expiry date. So if you think back to Rob's presentation, it's the date at which the stock item will retain its strength and other properties. And on SVS, it's the first expiry date that must be recorded for the vaccines. Marion, you can skip ahead. I'll touch on these in the next slides. So the stock receipt field, it's the stock received from a supplier, distributor, depot, primary distribution site, or a primary vaccination site. These are recorded as vials and not doses, and does not include vials returned from outreach services. Versus stock returned, which is not actually a field available in SVS, so we don't actually have a place for this. So it's not unused stock returned from outreach services, and it must be deducted from the stock issued for the day. That's why it's not its own field. Thank you. Next slide, please. And then for the stock loss field, it's for full vials wasted due to either breakage, expiry, just missing inventory, or if the vials experience temperature excursions. And it's also recorded in vials and not doses, and does not include partially used vials. If you look to the left of your screen, you'll see the options for stock loss reasons as it appears on the SVS device. The stock issued field is stock used during the day at vaccination stations or outreach services. Again, it's counted in vials and not doses. And this also includes partially used vials or opened vials. Then lastly, we have the stock transferred field, and that's stock sent to another primary vaccination site or distribution site, but does not include outreach services. Again, vials and not doses. Next slide, please. So in order to maintain data integrity, the current stock level is calculated as the opening balance plus receipts minus the sum of issues, transfers, and stock lost. And for each of these, you capture the total of all events that occurred during the day or the week in terms of ancillaries. And also remember the last updated stock levels for the day will reflect the day's closing balance and become the next day's or week's opening balance, as the formula states. So on the right-hand side, you see a screenshot of an SVS device. So it says there the current level. So that will be the opening balance for the day. And you can see it's also for the COVID-19 vaccine, and it shows you the code, inventory code. And below that, you'll see where the user would now go and update the various fields for this item. Next slide, please. So quickly, some do's and don'ts on how to report on your COVID vaccines. So all vaccines must be updated on daily. So if they have 2 vaccines on the formulary, update on both of them, even if one does not have stock. So the don't is don't update on only one vaccine, or don't skip reporting days. And then always update the totals of all events that occurred during the day for all capturing fields accurately, and don't omit transactions and capturing fields. Do update once a day, and don't input duplicate entries on the SVS fields. Bear in mind, only the last update per item for the day will be recognized as the update for that day. So don't update daily cumulatively. So that shouldn't be the running sum of all that you've issued or all that you've transferred. It should be just the transactions for that day. And again, don't update multiple times per day. Make sure you update data for all days missed on the day of capture. So you'd add, again, the days missed plus the current day, but don't update incorrectly after skipped reporting days, and don't make multiple updates per day to account for skipped or reporting days. Do capture partially used vials as stock issued and not as stock lost. and capture the earliest occurring expiry dates for all batches according to the storage conditions and the guidelines, according to Rob's presentation again, and don't capture stock expiry dates as per the manufacturing expiry date once vaccines have moved to a different temperature range. And then just finally at the bottom, inaccurate data entries on the COVID-19 vaccines can only be corrected for the day in question and not for past reporting cycles. So that's why it's very important to get it right the first time. And stock levels cannot be captured retrospectively in SVS COVID-19. Once the updating window is missed, the previous day's updates cannot be made individually. So again, very important to stay current with your reporting and not to skip reporting days. Next slide, please. Okay, thank you. Back to you, Marianne.
Sorry, for some reason, I had a challenge unmuting myself. Thank you. So I'm going to take you through the topic of vaccine wastage. There's been a lot of discussion about vaccine wastage and how to minimize vaccine wastage in both the private and public sector. But first, we need to understand that there's two different types of vaccine wastage. So vaccine wastage occurs in most vaccination programs. Even if you use single dose presentations, it's still possible to have vaccine wastage. And vaccine wastage can be divided into two categories. The one is wastage in open vials, and the other is wastage in unopened vials. So we'll first focus on wastage in unopened vials. So wastage in unopened vials or closed vials is unacceptable and is usually due to poor stock management practices or poor cold chain practices or poor logistical decisions. This type of wastage can be eliminated from your program completely. And the wastage that occurs in unopened vials is wastage due to expiry, or a VVM that has reached its discard point. Currently, the vaccines that we use in the COVID-19 program don't contain VVMs, but they might in future. Or exposure to heat or exposure to freezing, or vaccine vials that are either broken, missing, or theft within your facility, or doses that need to be discarded at the end of an outreach session because it wasn't stored correctly during the outreach session. And then we also have wastage in open vials. This wastage occurs in an attempt to increase the immunization coverage. So this type of wastage is the one that we want to not necessarily discourage. We can never eliminate wastage in open vials completely. We can minimize it by which will improve the efficiency of our program, but reducing vaccine wastage should never be at the cost of immunization coverage. So wastage in open vials, we would say, is more acceptable. And this is when you draw up the number of doses, but you're unable to get all the doses as indicated on the vial. And we often see that if you're using the wrong ancillary supply, so the wrong needle and syringe combination with the Pfizer vaccine, for instance. So you are supposed to get 6 doses from that vial. But if you're not using a low dead weight volume syringe, then you will only get 5 doses from the vial. Or you have to discard the doses remaining at the end of the session. So we know that once you have opened either the Janssen or the Pfizer vaccine, after 6 hours, you need to discard the open vial because these vaccines don't contain preservatives. So once the 6 hours have lapsed, regardless of the number of doses remaining in the vial, you would have to discard it. You also have to discard all the doses remaining at the end of the day. So that, because obviously before your next vaccination session, the 6 hours would have lapsed as well. And then we also have poor reconstitution practice. So this is where, especially with the Pfizer vaccine, if you don't dilute the vaccine correctly, then you are unable to get the number of doses as indicated on the vial. Or if the open vial is submerged in water. So if an open vial is submerged in water, the vial becomes contaminated and therefore has to be discarded because it's no longer aseptic. And lastly, patient reaction. So we often see patient reaction when people are scared of getting vaccinated. And as you move with the needle towards their arm, they might pull away. They might even get up and leave, resulting in the vaccine being injected into the air. So vaccine wastage occurs in most vaccination programs, as I've indicated, and the question remains if you can reduce vaccine wastage, which will then improve the efficiency of your program. Vaccine wastage can therefore be defined as the number of vaccine doses discarded, lost, damaged, or destroyed during distribution, storage of your vaccine, or the use of the vaccine. A well-managed immunization program reduces reduces the cost of the immunization program by improving the efficiencies without compromising the quality of the service provided or immunization coverage. So the WHO has set out indicative wastage rates, which is the wastage that we can expect depending on the presentation of the vial that you use within your program. So for a 5 to 6 dose vial, the expected wastage is between 5 and 10%. So as we are providing our services in South Africa, our wastage that we have detected in our immunization program is around just below about 5%. So actually currently in both the private and public sector, we are doing quite well. But we have to ensure that the measures that we implement to reduce vaccine wastage doesn't compromise our immunization coverage. And this is a very big risk, especially when there's low demand for the vaccine, as we have at the moment. So someone might present at a vaccination site at 10 minutes to 4, and then the vaccination site manager might indicate, we're not going to open a vaccine vial for you because there's not 6 people in the queue, or there's not 4 people in the queue, or we're closing in an hour, and then we would have to discard this vial. The biggest risk is that these people will not come back to our vaccination sites. They will also not present to another vaccination site because their trust in the vaccination program has been reduced. So one of the biggest risks is trying to reduce vaccine wastage at the cost of immunization coverage. So it's something that we should be aware of. So what tools do we have available to monitor vaccine wastage in our immunization program? So firstly, we have to understand the different types of data sets that we have available. So firstly, as Yash has now described, we use the SVS. So SVS is stock visibility system, which is used in medicine storerooms or in pharmacies, meaning the places where the vaccines are stored overnight. So we might find that in a clinic, and we might find that in a pharmacy, and the vaccines that were used at outreach services and at vaccination sites, those vaccines would return to the medicine storeroom or the pharmacy at night, where the data will be recorded on SVS. One thing that you should remember about the data being recorded on SVS is that we record this data in the number of vials and not the number of doses. On the other hand, we have the EVDS system, the electronic vaccination data system. This system is used at vaccination sites. So it's used at fixed outreach sites, at temporary outreach sites, inside clinics, and in mobile vehicles. And the number of vaccinations are recorded in the number of doses administered, which is a very big difference that you can see between these two data sets. The one is used where the SVS is used where vaccines are stored, but not necessarily where vaccines are administered. And EVDS is used where vaccines are administered and recorded in the number of doses. So when you calculate vaccine wastage, you always have to convert your number of vials into number of doses. So the number of vaccine doses and not the number of vials is used when you calculate vaccine wastage. So when you calculate vaccine wastage at storage level, we recommend that that should be calculated at least once a month, and that's usually done when you do cycle counts. And you might find that there was vaccines that was exposed to freezing, or vaccines that's exposed to heat, or expired vaccines, or vaccines that was damaged or missing. If you find that, that should be recorded as doses lost on SVS. You can also use a stock loss card that would help you determine what is the cumulative reasons for why vaccines are being disposed of while they are still at storage level, so that you can address those. So if you find that every week you are writing off vaccines due to freezing, then you can look at how to improve the quality of your cold chain. If you find that every week you have missing doses, then obviously you can investigate within your facility why your doses are, or why your vials are going missing. When you calculate vaccine wastage at storage level, the most suitable indicator for calculating vaccine wastage at storage level is the proportional wastage in unopened vials. And the formula for calculating vaccine wastage at storage level is the number of doses discarded divided by your start balance and the number of doses received. Since we usually store large volumes of vaccines at storage level, meaning within your depots or your pharmacies or your medicine storeroom, any wastage at this level usually has a significant impact on your vaccination sites. There's no acceptable wastage rate at storage level. As we indicated, all of the types of wastage that can occur in unopened or closed vials are avoidable. So if you have a wastage rate which is greater than 1%, an additional intervention and investigations at your storage site is recommended. If you wanted to calculate your wastage at your service delivery level, it is important that you record specific data sets. These data sets can be recorded on a vaccine stock card. So as I've indicated, with the data that we have available, the SVS data, which is an electronic data set, and the EVDS data, which is also electronic data, with those two data sets, we cannot calculate vaccine wastage at service delivery level. So if you wanted to calculate vaccine wastage at service delivery level, we recommend that you implement a vaccine-specific stock card. There are specific fields that is required to do these calculations, such as the number of doses that are discarded unopened versus the number of doses that was opened for use. So the vaccine stock card is available in a tool which you can also download from the Knowledge Hub if you wanted more information on how to calculate vaccine wastage at your service delivery level. You can, however, with the data sets that we have available, calculate the overall wastage of your vaccination program. And to calculate vaccine wastage, we first start by calculating vaccine usage, as vaccine wastage is the opposite of vaccine usage rate. So we would start with the number of doses administered. So if you are working at a clinic, you would say how many doses was administered in vaccination room A or in the clinic today, how many doses, not vials, how many doses was issued for the vaccination session that day. And then you would divide the number of doses administered by the number of doses issued, multiplied by 100. So for instance, if you find that your vaccine usage rate is 95%, then your vaccine wastage rate, which is the opposite of vaccine usage, would then be 5%. Then you would calculate that your vaccine wastage rate of 5% is still within the acceptable WHO indicative wastage rate, and therefore additional interventions might not be required to reduce your wastage any further. If your vaccine wastage, however, exceeds 10%, further investigation is required, and additional tools should be implemented within your vaccination site to determine if the wastage that you have at that site is either avoidable or unavoidable wastage. The SVS and EVDS system does not allow us to do any further investigations other than determining your overall vaccine wastage rate. So if you wanted to understand what proportion of the total wastage is either due to avoidable or due to unavoidable wastage, which would then in return allow you to develop specific interventions, you have to implement a vaccine stock card where the vaccines are used at service delivery level. So the challenges with developing interventions is, firstly, we have to determine if the vaccine wastage is high. So you would start with calculating what the overall wastage of your vaccination site is, and then compare that to the WHO indicative wastage rates. If your wastage rates exceed 10%, additional interventions might be required. Vaccine wastage must always be reviewed with immunization coverage over time. And that is important so that you can see that any intervention that you have made have not reduced your immunization coverage. It should be noted that vaccine wastage will vary over time, and therefore vaccine wastage calculation should be considered as a continuous process. And this is very evident now when we have low demand within our vaccination program. So in September last year, when there was extremely high demand within the vaccination program, wastage would have been less because there was long queues for people waiting to receive the vaccine. But currently, there are shorter queues, which then tends to result in higher vaccine wastage rates. Monitoring vaccine wastage allows the program to improve the forecasting, which prevents vaccine stockouts and overstocking. So if you understand how much vaccine doses you are expected to lose in the next month, then you know how to estimate to ensure that you have those additional doses available. And if someone presents at your vaccination site, that you can be sure that you would have the vaccine available to provide the service. It also improves vaccine presentation selection. So currently we are not choosing any other vaccines, but if in future we were to go out on tender, for instance, to procure these vaccines, we might select to move to a one-dose vial presentation, which will then have a lower vaccine wastage, although the indicative wastage rate, even for a single dose presentation, is around 5%. And it will also assist in determining the cold chain capacity that you require. So if you know how many vaccine vials you are supposed to have at your site to ensure that the demand in your community is met, then you understand how much space you must have in your fridge to ensure that those vaccines can be stored safely. And obviously, it will also assist you to provide outreach services. I'm now going to hand over to Dr. Sophie. We are going to discuss the client journey and the administration of COVID-19 vaccines. And we have changed around the learning objectives. So usually we start with EVDS, but tonight we are going to start with the outline of the eligibility of the COVID-19 vaccination, contraindications, the safe administration of the vaccine, and then provide updates on the immunization schedule, and then only move to EVDS. Dr. Sophie, if you're ready, you can start.
Thank you very much. We can start. So with regard to COVID-19 vaccination, everyone above the age of 12 years is eligible to receive the vaccines. All pregnant women, regardless of their stage of pregnancy, the lactating mothers, even the non-pregnant women contemplating pregnancy, those who want to have babies, they are eligible. And COVID-19 vaccines might be administered with other vaccines, regardless of the timing, meaning they can be given at the same day. The only important thing to note here is they must be given at different injection sites, and the COVID-19 must always be administered on the left arm. So people who have had COVID-19 in the past should have an interval of at least 1 month since recovering from the infection, meaning since they have also been cleared of the symptoms. People who have had COVID-19 monoclonal antibody convalescent plasma treatment in the past must have an interval of 3 months since the treatment before they can receive the vaccine. Next slide, please. So the only contraindication to COVID-19 vaccines is when the person has a history of severe allergic reaction to any component of the vaccines. Always refer to the professional information of the vaccine to be administered for details on the vaccine component. People with autoimmune condition must consult their doctor before being vaccinated. We are also aware that immunocompromised person may have reduced response to any of the COVID-19 vaccines and may require additional doses, as is going to be indicated in the schedule. Anyone who experienced the following symptoms a few days after the vaccination should seek prompt medical attention. The symptoms include neurological symptoms, which include severe or persistent headache or blurred vision after vaccination, skin bruising beyond the site of vaccination, shortness of breath, chest pain, and pain in the lower limbs. Next slide, please. It is important to obtain informed consent before administering any COVID-19 vaccines, and we must make our client aware that no vaccine is 100% effective, like any other vaccine. COVID-19 vaccines are the same. So to obtain the consent, we must inform them about the efficacy, which is not 100% always, and which vaccines are they receiving today? What are the possible adverse events following immunization? The need for any subsequent vaccine. So they should know that if they have received Comirnaty, when is the next date for the next vaccine and how many vaccines are they going to receive? And also the possible side effects. So for them to receive the vaccine, the client must digitally confirm consent or sign the paper consent form if they agree to be vaccinated. So it is important that we inform our people before they sign the consent form. Next slide, please. Coming to the preparations of vaccines. You must always keep vaccines in a passive container and protected from light. Always maintain cold chain as indicated earlier. Which temperatures must we maintain our vaccine in? Prepare each vaccine according to the manufacturer's instructions, as we will be aware that our Janssen is a multi-dose vial, but it does not need reconstitution, whereas a Comirnaty vaccines, it needs reconstitution. So we need to prepare each according to the manufacturer's instruction. The following is not allowed. Do not pre-draw the vaccines and say, no, the queue is too long, as it might happen in other facilities. So I'd rather withdraw all these doses from the vaccines, the Janssen vaccine, so that I can administer as the people comes in. That is not allowed. We only draw when the client is in front of you. Do not leave the needle in the syringe in a vial. It's a infection threat. Actually, we are exposing people to cross-infection. Do not turn client away because they are not enough for opening a new vial. As it was indicated earlier, this is an acceptable wastage. When somebody comes 3:30 and you think that is the only person for the last person for the day, and we may need to open that vaccine. We can't turn that person back and say, if we open it for you only, we're gonna lose 4 doses. No, you rather risk vaccine wastage than risk the issue of having low immunization coverage. Next slide, please. The vaccine administration process. Always disinfect hands before starting with the procedure. It's always advisable to wash our hands. Before opening a vial, confirm that the vaccine has not expired. Clean the rubber stopper of the vial with cotton swab moistened with clean water. Before each withdrawal from the vial, draw up required dose according to the vaccine-specific instruction using a sterile needle. Follow the 1 needle, 1 syringe, 1 time policy, where we use the same needles that we have withdrawn to inject, and when we dispose it as 1 set. Expose the arm completely from the shoulder to elbow. Next slide, please. After exposing, you need to identify the injection site, which is the 3 to 5 centimeter below the acromion process in our deltoid muscle. Clean the skin with cotton wool moistened with water, not an alcohol swab. Do not soak the cotton balls or swab in the water and leave them for the day, for saying that I don't want to be wetting them every time. I put them in this water and every time I just take one. That one is not allowed. Administer the required dose of vaccine into the deltoid muscle of the non-dominant arm. Inject the vaccine by holding the syringe firmly between the thumb and forefinger and inserting the needle into the densest population of the muscle at a 90-degree angle, as we know that our COVID-19 vaccines are administered intramuscularly. Do not administer COVID-19 vaccine intravascularly or subcutaneously. Next slide, please. Inject the vaccine slowly and remove the needle quickly. Apply gentle pressure with a sterile gauze or a cotton wool. Do not rub the site, as this interferes with the absorption of the vaccine. Do not, discard the needle and syringe as one component without disconnecting or even recapping the needle. All this must be discarded into a sharp container as one component. Disinfect your hands and make the client comfortable. Next slide, please. After administration of the vaccine, the vaccinee moves to the observation area where she will stay for 15 minutes or 30 minutes if they are considered a risk for anaphylaxis. We must not also forget the recording, that in this part, we need to record the vaccines that has been administered, the site, the expiry date, and the batch number on an EVDS. If the vaccinee experience an adverse event following immunization, they will be attended to on site following the standard treatment guideline for treating anaphylaxis as indicated on the right of our slide, or be referred for further clinical care. Any adverse event following immunization must be documented and reported as set out in this section of the standard treatment guidelines. Next slide, please. Let's now look at the current standard schedule as of the 14th of March, 2022. If the client has received a Comirnaty vaccines, they should get the second one within a minimum interval of 21 days. That's when they get the second one. And then they will then get a booster within a minimum interval of 90 days. The booster can be in the form of a Comirnaty vaccine or a Janssen vaccine. And if a person is 18 years and older and has received also Janssen vaccine, may get the second one within a minimum, which we consider as a booster, because when Janssen vaccine came, we knew that it was only a single one. It didn't have a second dose. So the person will get a booster within a minimum of 16-day interval. And they are also eligible for another booster in the minimum interval of 90 days. And the booster can either be in a form of a Janssen or a Comirnaty vaccines. Next slide, please. So for the immunocompromised adults, this is the schedule that has been registered after the 11th of April. For those who are immunocompromised, they will receive the first dose of Comirnaty. And then within that, after the 21 days interval, they'll receive the second dose. These individuals are also eligible for another additional dose. It's not called a booster, it's an additional dose for them after 28 days to 3 months interval. Then later, after 98 days interval, they can then get the booster, which can be either as community or Janssen. Or if the person has received the Janssen, 28 days to 3 months, they can receive an additional dose of the Janssen. Then 60 days interval, then they can receive the first booster of Janssen or community. And then after 90 days interval, they can receive the second boosters. As indicated earlier, we can see that in these groups, they are actually eligible to more vaccines as compared to those people that are not immunocompromised due to the effect of how they may not gain immunity as compared to not immunocompromised or healthy individuals. Next slide, please.
Thank you, Sophie. So we'll give over to Olka. Olka, are you ready?
Okay, thank you.
Thank you. Apologies for being late, colleagues. So I'm going to take you through the EVDS workflow process. I think that as it goes through the client journey, and one of the easy ways to think of this is that as the client proceeds through, they shed pieces of data, and a lot of this data is recorded into the EVDS, the patient record system. Next slide, please. Next slide, please.
Hi, Olka, it has moved. I'm not sure if it's your connection.
Are you not able to hear me?
Now you're better, thanks. You can go
Oh,
on.
okay, thanks, Marion. Yes, I am. The connection is probably not perfect here. So just looking at registration, I'll just take you through it. I'm not going to spend too much detail going through this process because I think a lot of us are very familiar with it. But what I will do is after this, talk a little about the new developments with EVDS. So as the clients have to enroll on the EVDS, so you can enroll yourself or on USSD, or they can be assisted. The enrollment can, someone can help them, or when they go to a vaccination site, the administrator will help them register. And so eligible people enroll, as we've said, and then the EVDS will send an SMS to the client to confirm enrollment vaccinated. And then the on-site registration assistant, so the administrator, might help you with enrollment onto EVDS. The exception to this is an undocumented individual, which I will discuss later. Next slide, please. Next slide, please. Thanks. So a client can schedule their own appointment when they enroll themselves on the via the EVDS, but also you don't need an appointment. So as long as you take your identifying document, or even if you don't have an identifying document, you can be what we call a walk-in. The client can just walk into the site and they can be vaccinated EVDS, but they don't necessarily have to do it before and book an appointment. Next slide, please. Next slide, please. Thank you. I think there's a delay. Okay, thanks, noted. Noted, Doc. So, of course, once the client arrives, they are screened for symptoms. If they don't have some of these client details, so their demographic details, the name and so on, will be confirmed on the system, and they will be directed to the wait. Slide,
Hi.
please.
Sorry, Alka, we actually lost you. I think the last thing we heard is that they should move to the waiting area. Is that fine?
That's where I was. So then we can move on to the next slide.
Okay, thanks.
Apologies, colleagues, for my connection. Right. So a client will have to present with their vaccination code, which they will receive via SMS. And then they have to bring proof of identification to confirm, and then they show that to the administrator, the site administrator. If their name is incorrect, they must re-enroll with the correct information, and the site administrator can help them. And please note the little yellow star. If the client's an undocumented process. Next slide, please. Who is an undocumented person or an undocumented individual? So these are people who have been identified as part of a vulnerable and hard to reach population. It might maintain an ID or can't even renew or replace their ID with an affidavit. If the person can, if they've lost their ID or it's been stolen and they can go to Home Affairs and get a new one, that is not counted as an undocumented person. They will have to return to the site with identifying documents. It could be a homeless person who doesn't have documents, and it could be an undocumented foreign national. So whoever you are, even if you don't have documents, you're still eligible to be vaccinated. There will just be a very specific process that you have to go through on the EVDS. So the administrator, so this is the first scenario, is that the administrator in every case will confirm that there are no identifying documents. And then an administrator who can log onto the mezzanine system can use their credentials, their password, to generate a vaccine code. Now, as you know, many of the vaccination codes that you will see on EVDS do not start with UC. If it starts with UC, it means an undocumented individual. It stands for undocumented citizen, but as I said, these are not only citizens. They could be foreign nationals without documents. And then the client will receive the code, their UC code, via SMS if they have a phone number. And then they can continue to the vaccination station with that code. What I suggest is that the administrator writes that code on their vaccination card so that the administrator has some vaccination cards at their station before they proceed to the actual vaccination area. And then they don't have to play a broken telephone and have to keep repeating their UC code. It's written down and they can present it to the vaccinator. The usual process where the vaccinator will write that UC code on the vaccination card and record their vaccination, and their vaccination will be recorded on EVDS. As soon as they generate the UC code, the vaccinator will be able to look up the person on the system and cap. Next slide, please. Thank you. The second scenario is where the administrator confirm document and they contact the call center. So this would be what we call a virtual administrator. and I think my voice might be, my connection's not, oh, there we go. And they would get a UC code and then give that to the client. So it's not ideal, especially in the case of someone who is an undocumented immigrant, because of course there's a lot of challenges for people who do not have papers or who might be from other countries. So they might be very hesitant to proceed if they see you getting on the phone and asking you to wait. So just to be mindful of that and reassure the client. And then they will be given their code that the administrators received from the virtual call center, and the vaccinator will write it on the vaccination card. Again, the administrator might want to write this have some vaccination cards at the administration desk and write it onto the vaccination card and give it to the client. I just want to state that I'm mindful that there may not be this exact structure at a private vaccination site. It might be set up slightly differently in terms of the administrative desk and so on, but this is the process that needs to be followed. Next slide, please. Next slide, please. Slide, thank you. All right, so this is the third scenario, in which case you would treat this vaccination exactly as you would treat any vaccination where you did not have connectivity or you had no power, or the EVDS system was offline. So in this case, you would use a paper-based form to record the client details, and then the client would take their form to the vaccination station, and the vaccinator will complete the form after vaccination. So these forms will then be summarized and emailed into X, and that location will generate the UC codes, and the client will receive the code via SMS if they have a phone number. Then the codes will be sent back to the site, and the paper forms must be back captured into EVDS. So bearing in mind that you can't capture someone who doesn't have the vaccination code, who doesn't have the registration code, this is why you would have to wait until you had a certain number of paper forms and then capture the details into an Excel spreadsheet. And when I say detail, demographic details, so date of birth, name, surname, phone number, etc. And then with the codes, and the person who has been nominated to do the data capturing on the site will back capture the paper side. And I know that it seems a bit, if you do have any questions, please do feel free to email me, and I can also set you up with specific training if there are any concerns. But usually, I hope you would not be using paper forms. Thank you. So now we have the rest of the client journey, and I think the most important part, where the client actually has will provide consent prior to receiving the vaccine, and the vaccinator must record this consent. They must click in the EVDS that the client has provided consent, and then they administer the vaccine. Okay. And only after they've administered the vaccine, record the vaccination on EVDS. And their mind about which vaccination they want to have, and then you will have captured it as Johnson & Johnson, and then the person changes their mind and wants a Pfizer vaccine. And then another reason is that people sometimes decide not to go ahead with the vaccination. So then, of course, if you have already captured it, incess that needs to be followed to undo that. And EVDS records the time and the date automatically. And again, to the mobile number of the vaccinee, and they will receive their code, their vaccination code, confirming that their vaccine was administered. They are coming back to complete their primary schedule. So if it's a Pfizer vaccine, then they will receive a reminder SMS. Okay, closer to the time when they're due for the next, for the dose and the schedule completing dose. Next slide, please. Thank you. And again, I'm just going to perhaps hammer this point home. Follow the following steps. Only update the EVDS after the vaccination. Double check that you've selected the correct vaccine type. These are things, common errors that we find, and the developers have to go and change the record, and it's quite a complicated process. Ensure that the vaccination card matches the EVDS record so that it's correctly written on the patient's card. Avoid the use of paper forms unless it's absolutely necessary, colleagues. So only use it when there's no power or there's a connection failure or the EVDS is offline. And that hardly ever, that you don't often use paper forms, and that if there are paper forms in your facility, I would like to capture them. If a paper record's unavoidable, then complete every field on the form and capture it within 24 hours. Next slide, please.
Thank you very much, Olka. We much appreciate you struggling through your presentation with your limited connection. I did see that there's some questions related to EVDS in the Q&A. If you can attend to those, and I'll discuss the circulars. Thanks.
Will do, thank you.
Thank you. Okay, so on this page, you can see all the circulars that has gone out since the start of the program. And there has been various changes in expiry dates, changes in eligible population, changes in immunization schedules, changes to the immune-compromised schedule. So I think it's really important that you access these circulars so that you can see the way that the program has evolved over time. All of these circulars have been loaded on the Knowledge Hub, and I will post the link in the chat for you so that you can access these circulars if you want to read them. There was another 2 circulars that's currently not included there that will be loaded. The one about the change of the expiry date of the Pfizer vaccine when stored at -70 will be added to that catalog. And then also a change, we previously recommended that the Janssen vaccine should be used in rural settings, and we will shortly be issuing a circular that says that the Janssen vaccine, even though we haven't limited the access to the Janssen vaccine in any way, but we have now issued a circular saying that it can be used in both urban and rural settings. So in the chat, I will paste a link to these circulars at the end of the training, because I need to access it somewhere else. While we are busy with the Q&A, and I will post the links to the circulars there. But really, it does give you a great view of how the vaccination program has evolved over time. We are now going to move to reporting of adverse events, or the Vaccine Safety Surveillance Network. And I want to say a special thanks to Professor Hanneli Meyer, who is joining us from Spain tonight. So we have an international speaker that will be presenting on vaccine safety surveillance, and really she's an expert in the field as the chair of the National Immunization Safety Expert Committee. Let me just check, Professor Meyer, are you ready? And then I can mute.
Yes, thank you, Marion. Can you hear me?
Clearly, thank you.
Okay, that's great. Okay, so thank you very much, and good evening to everyone. Thanks for joining this this webinar, this training session tonight. And yes, I'm joining you from Spain, so I'm feeling very relaxed. So okay, so let's have a look and at what's been happening within the vaccine safety surveillance space. So this module will give you some up-to-date information on the latest processes being implemented for vaccine safety surveillance for the COVID-19 vaccines. And this includes adverse events following immunization reporting, the investigation process, as well as causality assessment. Next slide, please. So it's very important, for everybody to know exactly why vaccine safety surveillance is so important. So firstly, we need to verify that the rates of adverse events following immunization, or IEFI, as we call it, occurrence in the local population compare well to the trial data as well as international data. So in other words, we need to know that we are seeing the same trends in terms of adverse event reporting when we are rolling out the vaccine now to millions and billions of people. Then also to detect and immediately correct and prevent immunization error-related events. So Marion also referred to some of those. So if we pick up anything like that, because of the reporting process, then we can immediately do something about it. Then to identify if there are any problems with the quality of the vaccines itself. So this fortunately is very rare, and hopefully we will not see anything like that, but it's also very important, in terms of safety. To reduce incidence of immunization stress-related responses as a result of fear of needles and pain through educating the public, good messaging and so on. To monitor, to prevent any morbidity and mortality as a result of the COVID-19 vaccines. So we need to be aware of that in case something like that happens. To prevent false blame from the public arising from coincidental events. And that's also why we are sharing the data on the SAPRA microsite, which I will talk about a little bit later. And then lastly, to maintain confidence in the program and the vaccines itself by addressing concerns and raising awareness about vaccine risks. Next slide, please. So this is a very important slide, and we cannot emphasize enough the definition of an adverse event following immunization, which is not the same as an adverse drug reaction. So an adverse event following immunization is any untoward medical event which follows immunization, which could be a sign, a symptom, a laboratory finding, or a disease. And what is important is that it follows vaccination, but it has not been proven to have a causal relationship with the use of the vaccine. And this is why we first need to investigate and then assess whether the adverse event is vaccine related. So often you would find in the literature where people misinterpret spontaneous reporting as these events being caused by the vaccine without it having been investigated. And then it creates a lot of confusion and fear amongst the public. Next slide, please. So if we look at a cause and effect relationship, it is between a causative factor, which is the vaccine in this case, and an outcome, the adverse event. So firstly, like I mentioned, they are, these events are temporarily associated, meaning that the vaccination preceded the event. So the vaccination happened before and not after the event. Secondly, there should be no other factors intervening in the process. So events that are temporarily associated may not necessarily be causally associated. And it's human nature for us to blame things on a single major cause. And we all often make this kind of mistake of blaming something that occurred earlier. So when we do that, we actually make an error of reasoning, which we refer to as a logical fallacy. So we assume that one event must be the cause of a later event simply because it occurred earlier. And these kind of logical fallacies, they are also the basis for so many misconceptions that were believed in the olden days, and then also the misinformation that is flooding social media now, in modern times, and especially since the COVID-19 pandemic. So, firstly, when the pandemic started, and then also when the vaccines were developed and being rolled out. Next slide, please. So with the COVID-19 vaccine introduction, we also monitor adverse events of special interest. So these are pre-specified medical events that have the potential to be linked with a vaccine product. For example, anaphylaxis. So these events are being shortlisted by global authorities such as the WHO. There are definitions formulated for these specific events by, the Brighton collaboration. And these must be very carefully monitored through active vaccine surveillance, as well as spontaneous reporting. So the incidence of adverse events of special interest for the COVID-19 vaccinated and unvaccinated individuals can then be compared. So this will enable us to determine if there is a link between the adverse event of special interest and the COVID-19 vaccine product. So if we investigate and we look, these kind of events, we do then causality assessment for them. We always compare the rates of people being vaccinated with these kind of events with those of unvaccinated individuals presenting with the same kind of events, to make sure that there is no sudden increase in these types of events. And then if so, if there is like a possible signal, then, further studies might be necessary to determine whether there could possibly be a causal link between these events and the vaccination. So here you can see the current adverse events of special interest defined by the Brighton collaboration for the COVID-19 vaccines. And this list is being continuously updated. And also, there are people working on definitions specifically for these events, and also how to diagnose them to make sure that, we are working with the correct diagnosis for the purpose of causality assessment. Next slide, please. So all the vaccines are tested during 3 stages of clinical trials on tens of thousands of people before they are approved, to make sure that they are safe, effective, and of good quality. So by the time they are registered or authorized by SAHPRA, we already know about the short-term side effects from these safety and efficacy studies. And as you can see, these are the side effects that we are very familiar with. We know they are mild. They usually disappear within or clear up within 3 days. Often you don't need to manage them with any treatment. And these are the ones that we know of. So post-marketing surveillance, like I mentioned earlier, is very important, which is why we need to report all adverse events following immunization, not only the severe ones, because we want to make sure that these events still, when they appear, amongst the population, the large population that we are vaccinating now, that these rates are actually the same as the ones that we have seen in the clinical trials, to make sure these vaccines remain safe to use. Next slide, please. So the vaccine side effects or adverse reactions, we are used to, call these side effects like with medicines or adverse reactions. They are expected to occur with a certain frequency. So as you can see here on this slide, there are some frequencies indicated. So, so it's in terms of the frequency, but then it's also in terms of the intensity. And then they can be then classified according to the intensity into minor reactions and severe reactions. And I'll also speak about that more in some of the other slides. So very common or frequent adverse events, as you see there in the first row, they are usually minor reactions. So common side effects or adverse reactions are understandable because the purpose of the vaccine is to prime your immune system and put it on alert. So you expect to see these side effects, and examples include fever, headache, pain at the injection site. And they occur in more than 1 in 10 people, as you can see there on the screen. So common side effects in the second row, they occur in between 1 and 10 people in 100 people. So between 1 and 10 people in 100 people would experience these common side effects. Now, in the last row, the uncommon side effects, they are not expected, and they occur in between 1 and 10 people in 1,000 people. So as you can see, very few people, but we don't expect those. So with post-marketing surveillance, which is important, when we identify certain side effects or adverse reactions that we haven't been aware of in terms of being very common or even uncommon, and they establish a positive causal association between that adverse event and a vaccine, and it's confirmed, then the adverse event will then be classified as an adverse reaction or a side effect. Then they also look at the benefit-risk ratio. It will be calculated, and if it remains positive, because so if it remains positive, and because it was not a known side effect or an adverse reaction at the point of authorization, it would then be added or included in the product information. So changes to the product information will then be made, which will include the expected risk of such an adverse reaction if it is very common. Sometimes it's very rare, and you cannot actually determine, because it is so rare, what the frequency is. So here you can see, if you look at the diarrhea and vomiting in green, these were added to the product information of the Pfizer vaccine since authorization. You can actually go to the EMA website, and they are really very good at updating the product information. So if you want the latest product information, you could always go to the EMA website, and they have it there for all the COVID-19 vaccines. If you can go to the next slide, please, Marian. So yeah, you know, this is like a visual representation of the rare and the very rare adverse reactions. And they are usually the more severe reactions. It's not always the case that these are severe reactions, but most commonly, these would be severe reactions. So they usually require clinical management. So examples of them include severe allergic reactions, for example, anaphylaxis. And these can then also be very vaccine-specific reactions to the antigen itself or another component of the vaccine. They are often only identified when the vaccine is rolled out to the general public. Because, you know, you can never power your clinical trials sufficiently to be able to detect these rare events in the number of people that you would include in your clinical trials. Although with the COVID-19 vaccines, we know that, for example, for the Pfizer vaccine and the Janssen vaccine, in the third phase of the clinical trials, we had more than 43,000 people participating in the phase 3 trials. So examples, as you can see here, include myocarditis and pericarditis. As you can see, they are here included in green. So these ones, they've only detected them once the vaccine has already been rolled out to millions and millions of people. And that's then when they investigated these as possible signals. They identified a causal association, and they have updated the product information, as you know, and we know now that these occur, and we know they occur in specific populations and in specific age groups, and we also know that these are very rare. So you would find them in less than 1 in 10,000 people. If you can go to the next slide, Marion. So people often talk about vaccine side effects and adverse events interchangeably, although these are not the same. So the way we can think about common mild vaccine side effects versus very rare, much more medically significant adverse reactions is on a spectrum as shown here on the screen, with very mild side effects being the most common, more troublesome side effects being less common. So then on the other side, the more severe unexpected adverse reactions being extremely uncommon or rare. So we must remember that they will never register a vaccine or any medicine for that matter if they know that these very severe adverse reactions are very common, because then it would mean that the vaccine or the drug is not safe. So mild vaccine side effects are to be expected, as I mentioned before, in many people, although the specific rates may differ according to the specific vaccine. It won't be the same for all the vaccines, so it might be slightly different when you are looking at different vaccines. Now, the serious adverse reactions are much more unexpected. These adverse reactions are a sign that something has gone wrong with a person's response to the vaccination, leading to these serious symptoms. Now, there's low public tolerance of vaccine adverse reactions. So, as I mentioned, vaccines are only registered when the frequency of severe reactions is very rare and when only minor self-limiting reactions are being reported. So minor reactions usually occur within a few hours of vaccination and they resolve after a short period of time, and they pose little or no danger, and often you don't even need to manage them with any treatment. Local and systemic reactions can occur also as part of the body's immune response and can also be triggered by other vaccine components. So it's not only the antigen, it could be one of the other components included in the vaccine. So vaccine safety communication is very important, you know, to make sure that when you inform your vaccinee or your recipients about, you know, what they can expect. So Sophie also spoke about that. It's very important that you inform them so that they don't feel insecure or they start panicking once they experience any of these adverse events, and also so that they know when they actually need to do something about it, as well as report it. So it's important to note that there's a difference between the terms serious and severe adverse events or reactions. So a severe reaction can have either a serious or a non-serious outcome. Now, a non-serious reaction do not necessarily lead to long-term problems. They can, however, be disabling to a certain extent, but they are rarely or they never life-threatening. While on the other hand, a serious adverse event or a reaction is more like a regulatory term, and there are definitions for this by the Uppsala Monitoring Center. And this could be any untoward medical occurrence at any dose that can result in death. It requires inpatient hospitalization or prolongation of existing hospitalization. It results in persistent or significant disability or incapacity. It could be life-threatening, could result in a congenital anomaly, or it could be of medically importance. If you're going to go to the next slide, Marion. So since the start of the pandemic, SAPRA and the EPI with the National Department of Health been working with the African Union Development Agency on its AU Smart Safety Surveillance or AU3S program. So this program was launched early in 2020. It's a 10-year program to strengthen pharmacovigilance in Africa. and it has been supporting the safety surveillance of the COVID-19 vaccines in 4 pilot countries, of which South Africa is one. Now this year, Kenya has also joined the program. So this is one of the reasons for the introduction of the MedSafety app. Next slide, please. So the key focus of the AU3S program is to strengthen cross-country collaboration on signal detection and management. So people often ask, so how do you actually detect these signals? Because signals you can only detect once you have a lot of data being available. And this is the advantage of this program, because all the data from the 4 countries and now Kenya as well are being pulled together, and then all the data is then being used to identify any possible signals or items of interest. And when something like this happens, then they would be looking into more detail into these specific reactions to make sure that the vaccines remain safe while we are using them, and now specifically for the African population. And this is then also being discussed by a team of experts called the JSM group, and that is been happening on a monthly basis. Next slide, please. So something then new for South Africa in terms of vaccine safety surveillance is the introduction of the MedSafety app. This is a mobile application free for download on Android and iOS devices. It's used for electronic reporting of adverse drug reactions for medicines, as well as then adverse events following immunization for vaccines. So the advantage is that it can be used by the public, by consumers, as well as by professional health professionals. And it replaces the need for paper forms and therefore strengthens data quality. It also has functionalities in terms of keeping you up to date with safety information, safety news. And you can also use it offline until you have an internet connection available, and then you can send your data through. Next slide, please. So another new item for South Africa, like I mentioned earlier on, is the SAPRA microsite for the adverse events following immunization for the COVID-19 vaccines. So here you can see a screenshot of the landing page. And then there's a menu on the left-hand side, and you can actually go to these items and explore them. You will find a lot of information about adverse events available on this microsite, as well as some of the reporting rates. For example, the very common adverse events being reported, the deaths following immunization. Shortly, there will also be more information available on adverse events of special interest. You can go to the next slide, please. Now, here you can see some examples. Like I mentioned, the top 10 most frequently reported adverse events following immunization. So what is important about this site is that this is spontaneous reporting. So whatever people, report will appear on this website. So these events, they haven't been assessed for causality unless it's mentioned specifically that causality assessment has already been conducted. So this is just what people are reporting, and that then appear on the website. If you can go to the next slide. So when an adverse event is experienced, there are 3 ways of reporting, either at the health facility, through directly to a healthcare provider, through the MedSafety app electronically, or by calling the hotline. So the report will then result in either a paper-based or an electronic report. Events could either then be, like I mentioned, either mild or minor events, which are events that we expect from the clinical trials, or it could be severe events, which can either be non-serious or serious. Now, all the severe events must be investigated. So investigation is done by the district surveillance teams in the provinces. They collect essential information and evidence for the specific case. They complete case investigation form. And then something new also is a consent form. that has been added to the paper-based case reporting form as well as to the MedSafety app. So this means when a person reports an adverse event following immunization, they already provide consent for their clinical records to be accessed. And this really helps with the investigation process. And it's very important because without the information being available, causality assessment cannot be conducted. You can go to the next slide, please. So once the investigation has been done, the case is being referred to the National Immunization Safety Expert Committee. And as you can see here, there are three very important pieces of information, if you can call it that, that is necessary for causality assessment. So first, case must have been investigated. There must be a specific diagnosis, and all the details and evidence must be available. And as you can see here on the screen, if we talk about essential evidence, then it means all the information about the person, about the event, about the vaccine, where it has been administered, the previous records of the person, in the case of a death, an autopsy report, any other medical history, and so on. We don't have that kind of information available. Causality assessment is basically impossible. You can go to the next slide, please. So, like I mentioned, these cases will then move to the National Immunization Safety Expert Committee. This is an independent committee being appointed by the Minister of Health. They provide independent advice to the National Department of Health. They then review all these cases. They use a very specific methodology established by the World Health Organization to do the causality assessment. That's been tested and recognized throughout the world. They monitor for any specific or potential signals, like I mentioned before, and then they provide independent advice. So a new addition also for vaccine safety surveillance is provincial committees that's currently being established in the provinces. So they would then do provisional causality assessment for the cases in their province, and then these cases would move to the national committee where the causality assessment will then be finalized, and feedback from that point will then be provided to the vaccinee as well as to or through the provincial and the district officers. You can go to the next slide, please. So for the purpose of causality assessment, the first step is to make sure that the case is eligible, meaning there must be a patient identifier. There must be a specific vaccine and there must be a valid diagnosis. So if you do get a case being reported and, all that it's, for example, a death, death is not a final diagnosis. Death is not a diagnosis. There must be a cause of death. So that is why the information being available is so important. Then the next is to look at whether there's strong evidence for other causes. In other words, you need to look at the medical history of the person, the clinical examinations, investigations that's been conducted. In the case of a death, an autopsy report or laboratory report. For example, if it was a COVID-19 disease or COVID-19 pneumonia case, there must be a PCR confirming that the person actually had COVID-19 pneumonia. Then the next one is to look at if there are a known causal association with the vaccine. So we look then at the product information. Do we already know that this vaccine, can cause such an event or such a reaction? So, and we also then at this point in time look at, are there any quality defects? Were there any immunization errors? Was it perhaps a stress-related response like Marion explained earlier on? From there, we also look at whether this event happened within, the time window allowed. For example, an anaphylactic reaction would mostly occur within the first hour of vaccination. So an anaphylactic reaction cannot occur 2 weeks or 3 weeks after vaccination. So it's very important to also look at the time window. Then whether there's strong evidence against the causal association. So whether there are already studies being published, we look at you know, a meta-analysis, at Cochrane reviews and so forth. And then lastly, whether there are any other qualifying factors. In other words, any pre-existing conditions, did the person have any comorbidities? Did the person have such an event in the past? Are there any allergies present, any medication that could have caused such an event? So it's important to look at all these factors to be able to establish whether there is a causal link between the vaccine and the particular event. If you can go to the next slide, please. Okay, so then we also then classify. So once we've gone through this whole process, then we classify these events. Firstly, those with a consistent causal association to immunization could then either be because of the product-related reaction, or it could be a quality defect related reaction, like I mentioned, if there's something wrong with the quality of the product. It could be an error-related reaction, and that's then where, you know, it's very important to make sure that you put corrective measures in place. And then lastly, if it is an anxiety-related reaction, because of fear of injection or fear of needles or people who faint. And about approximately 10 to 25% of people actually do have this fear of an injection or of a vaccination, where you would find that they would then faint after the vaccination. Very important to differentiate then also between an anaphylactic reaction and such an anxiety-related or a stress-related response, because you treat those differently. If you can go to the next slide, please. So then there's also the indeterminate category. So this would then be, you know, where there are these two types of indeterminate reactions. So the first one is where you would find there is a temporal relationship. You know, so it is consistent, there is a temporal relationship, but there is not sufficient evidence or definite evidence that the vaccine has caused this event. So when cases are being put into this category, we, you know, monitor data being reported from across the globe, and that's why signal detection is also very important. And if new information becomes available, we would then go back to those cases to determine whether there could be a causal relationship between the event and the particular vaccine. And there's also another category called B2 indeterminate, where you find there's conflicting trends of consistency and inconsistency with causal association. So in other words, there would be evidence for a causal association, but at the same time, there would also be evidence against a causal association. So these cases are then classified as indeterminate, and we keep an eye on them, like have a watch list where we make sure that we go back to these cases if new information becomes available. If you can go to the next slide, please. So unfortunately, some cases end up to being unclassifiable, and these are cases where we don't have enough information available. Like the example there on screen, you know, cases being reported by an unknown person, an unknown reporter, which could be a health professional or a consumer. We don't know from which province it is. We don't know the name of the person. We don't have the date of birth. We don't have an ID number. We might have, you know, the age of the person, that the person is, for example, a female. It happened 14 days after vaccination and the outcome was death. So in these cases, you know, you can do absolutely nothing with these cases because you're not able to contact these people. You can't investigate the case. And then unfortunately, these cases will remain unclassifiable until the day that you do have more information available about these cases. If you can go to the next slide, please. Now, death following immunization is very important, especially now with the COVID-19 vaccines. Now, something new also is a guiding protocol for investigation of death reported following vaccination. There is a lot of uncertainty amongst healthcare workers, specifically about what should be done. So, I mean, death from COVID-19 in vaccinated people can occur when the person has already been incubating COVID-19 at the time of vaccination, or the person contracted COVID-19 shortly after being vaccinated, before mounting an adequate immune response. So non-COVID-19 related deaths can also happen coincidentally. And these would have happened regardless of a person being vaccinated or not. You know, people suffering from chronic comorbid conditions, which presents, you know, with high present them with a high risk for death, especially amongst the elderly people. So the main goal that we must remember of COVID-19 vaccination is to prevent severe illness from COVID-19 and prevent premature death, especially amongst elderly people with chronic illnesses from COVID-19. But it cannot, you know, protect you against anything else but COVID-19. Also remember that elderly people are at a much higher risk of dying than the general population, and they are at the highest risk of dying from COVID-19, which is also why it's important to always compare the background rates of you know, a specific adverse event of special interest, especially in the case of death. So these COVID-19 vaccines, as I said, they prevent you from dying from COVID-19 if you are vaccinated in time. They cannot prevent death from a diagnosed or an undiagnosed chronic disease. So they can only prevent death from COVID-19. If you can go to the next slide, please. So this is the last slide, just to show you the communication cycle in terms of the reporting of adverse events, starting from where the vaccinee, you know, is reporting it to the healthcare system. From there, the investigation takes place. It happens, you know, in electronic format these days. After investigation, it goes through to the National Immunization Safety Expert Committee, where causality assessment is being conducted. All the information is also, you know, given or being transmitted through to SAPRA. At the same time, when feedback is being provided, the feedback is then provided back to the provincial committees, the provincial teams, as well as the district teams, and from there on to the vaccinee. So the information follows exactly the same route in terms of the reporting, but then also when feedback is given, you know, in the opposite direction, so that all parties would stay informed about the adverse events. That is the last slide. So thank you very much for your attention and acknowledgements to everybody who's contributed to developing, you know, strengthening the vaccine safety surveillance system in South Africa. So thank you, Marion. I'm handing back to you now.
Thank you, Prof. While you're still online, can I ask you this one question? The question is, can you vaccinate a client with uncontrolled hypertension or uncontrolled glucose levels? Thanks.
You know, it's actually a very difficult question to answer because, you know, people with hypertension and with diabetes, they are at a higher risk. We know that now from all the data. They are at a higher risk of developing severe disease should they contract COVID-19. So it's very important for them to get vaccinated. But now we must also remember the fact that your hypertension is not controlled immediately puts you at a high risk Okay, anything can happen to you. Also, when your blood glucose is not controlled, so immediately you are at a high risk because of that comorbidity. So should should there be an adverse event, then it's going to be very difficult because you are already at a high risk because of your comorbidity. So I would say, yes, people should be vaccinated, but if your condition is not well controlled, make sure that you are seeing your healthcare provider and that your condition gets controlled immediately. And I mean, that can be done very, very quickly, but then second to that, you need to be vaccinated. I don't know if you want to also add onto that, Marion.
Thanks. Yes, I mean, obviously, Prof, the other concern is that if a person has uncontrolled hypertension and then you vaccinate them and then they have an adverse event of increased hypertension, it would be very difficult to determine if the cause of the increase in hypertension was in fact the uncontrolled hypertension or the vaccine. So obviously, while we don't say that people should get their sugar tested before vaccination or their blood pressure taken before vaccination, it's important that people should be controlled for their chronic conditions.
Yes, exactly. Because if there is an adverse event, then you wouldn't know, what was the cause for that. But then also keep in mind that should you then, you put yourself at risk also, and if you do get COVID-19, that could also have a huge impact on, your blood pressure. So yeah, but I mean, very important for these chronic conditions to be well controlled, definitely.
Okay, thanks. Dr. Lesego, I think we can move to questions. So people in the participants can raise their hands and we can open their mics to ask live questions if they like. Thank you.
Yes, I've also reminded them in the chat. I see Rofiwa. Let me start with Rofiwa. Rofiwa, you may unmute your mic and make your comment or question. Yes.
Okay, thank you for an informative session. I want to find out with regards to reporting the stock levels on SVS. Which facilities register on SVS, and like if it's an outreach vaccination site, do they register on SVS, or is it only the primary vaccination sites and the secondary vaccination sites, and then the outreach sites are not required? And if they are not required to report on SVS, how are they required to account for the vaccines that have been used? With regards to the calculations of wastage and usage, who is there, when you register on MFL, is that a requirement that you should be able to submit those that kind of a report, or is it something that is done above facility level? And if it is done above facility level, do facilities get feedback in terms of their usage? And if they are not using, if there are findings or negative findings regarding their usage, is there anything that is done to assist the facilities, the vaccination sites? Thank you.
Thanks. So I think there's two questions. I will start with the answer on vaccine wastage, and then I will ask any of the colleagues on the SVS team to answer the SVS related questions. So on vaccine wastage, the reason why we explain how vaccine wastage is calculated is so that you can calculate it for your specific facility. At a national level, we can calculate vaccine wastage based on the number of doses that was issued to the private sector versus the number of doses that was issued to the public sector, and then compare that to the number of doses administered. And then we take the SVS stock on hand into consideration as well to determine the number of doses that would have still been remaining on site. And that's why at a national level, we know that our average wastage, or overall wastage is around 4.7%, which is well in line with the WHO targets. But at your facility, you might have a specific problem. So at your facility, you might realize that you are losing doses and you're trying to figure out what is the cause. Why are you not getting the number of doses administered versus the number of doses issued for vaccinations? And then that's where you would use it at your site to determine where your wastage is, so that you can design an intervention that will not reduce your immunization coverage, but will improve the efficiency of your own vaccination program. And then the question on SVS, any of the SVS colleagues, you're welcome to answer. Thank you.
Marian, I'll take it. Thanks, Rafia, for the question. So with regards to sites uploaded on SVS, so it's only sites that's storing the COVID-19 vaccines overnight that's required to report on SVS. So unless it's a fixed outreach site, any outreach services are not required to report on SVS COVID-19. The accountability and those transactions that occur at outreach sites must be accounted for by the primary vaccination site that's linked to the outreach service on the MFL, and where they also received the stock from. So for instance, if any stock was issued at an outreach service or any stock was lost at an outreach service, the primary vaccination site that it is linked to, and where the vaccine are stored overnight, and that's uploaded on SVS, that primary vaccination site will then account for the update on SVS COVID.
Thanks, Dr. Lesego. Before we take the next hand, there's a question which we like to answer live. Dr. Sophie, we've discussed the principle of one needle, one syringe rule, and why that is best practice and why that is the gold standard. Can you maybe expand on that, please? Thanks.
Thank you very much. I think the reasoning behind the one needle, one syringe is also with regard to the issue of the dosing. Remember, when we have a vial, we need to get certain amount of doses from that vial. And when we exchange the needles, we tend to lose some of the doses in the needles. And it has also been proven that there is no, when you withdraw correctly, there will never be an issue of the needle getting blunt. If we know where to input the needle when we drop the vaccines, it will not be blunt. So we are making sure that our vials, they give us the required amount of doses, and especially with also the use of the correct needle, because if you use incorrect needle, the vial is too big, especially the practices of the clinic, they will say, I withdraw with pink, then I inject with this one. So what happens to the vaccine that is in the pink needle that you are discussing, discarding?
Thank you, Dr.
So that is the main thing there. Yes.
Yeah, that's a really excellent answer, and obviously it also improves vaccine safety injection technique, because you're not tempted to change needles, and then you can also increase the risk of actually a needle prick as well. So there is a lot of benefits, but there is no disadvantages to using one syringe and one needle. Dr. Lesego, you can move to the next person. Thanks.
Yes, there is Huawei. You don't have a name, Huawei. P30, you may unmute. Maybe start with your name when you unmute. Huawei P30, thanks.
Good evening, everyone. I'm representing my private clinic in East London by the name of Siyokuphila Clinic. I'm nurse clinician Kutazwa Koshe. One of my questions is, I've got two questions quickly. Most of my clients were complaining of a painful affected arm, the one which was injected. And I would like to know maybe what could be the cause, because that thing is the one which makes clients to be not willing to take the vaccine. And then question 2. I would like to know also what can be given in the place of a client who has reacted in the vaccine. As we all know, the vaccine is to prevent the death, especially to those who have reacted, because we can't give, and yet this vaccine is needed to prevent the cause of death and to prevent a contract COVID.
Okay, thank you. I think your questions are clear. How do we prevent adverse events? And then what causes a painful arm? Thanks.
Okay, thanks.
Hello?
Yes, ma'am, it's okay. We will now answer the question.
I was saying, what can we give in the place of an adverse effect of this COVID, in the place of it? What can be given so that one also gets this COVID vaccine? Is there no measure, that is any medication which can be given to any medication which takes the place of COVID vaccine, seeing that one has had an anaphylactic shock?
Okay. I think she's asking if there's an alternate option, another vaccine or something, in case the patient has an allergy to the current vaccine.
That's
Thanks.
correct.
Okay,
Yes.
good. Okay, I will answer that question. I will ask Dr. Sophie to answer the question on how to prevent a painful arm, but I think we know what she's going to say. But let me answer the question on an adverse event. Okay, so firstly, before you get vaccinated, it's not known if you might in future experience an adverse event after receiving this vaccine, as it's any untoward medical occurrence. So we didn't know that this is going to happen. So before you get you are going for the vaccine, there isn't anything that you should do that will then prevent an adverse event from happening. As you know, we don't know what the adverse or what your reaction to the vaccine might be. If you've had a reaction to the vaccine, to a specific vaccine, you can then get the other vaccine. Remember, we have 2 vaccines on our schedule. We have the Janssen vaccine and we have the Pfizer vaccine. So if you've had a reaction to the Pfizer vaccine, then you can get the Janssen vaccine. If you've had a reaction to the Janssen vaccine, then you can have the Pfizer vaccine as a booster or as a second dose. And the program already allows that. But there is no other medicine that you can take that will prevent COVID-19 as vaccines prevent COVID-19. The alternative is that you would get COVID-19 and then you would get treatment, but that is for treating the medical condition, not preventing the medical condition. Prof, is there anything that you want to add to that, just to make sure that I was clear? Okay, Dr. Sophie, do you have some advice on how you can prevent a painful arm after vaccination? Noting that, you know, local swelling is actually one of the common side effects of both of these vaccines.
Okay, thank you very much, Marion. I think it goes back to injection technique, the correct injection technique. We know that all vaccines are supposed to be given intramuscularly and the 3 to 5 centimeters below the acromion process. And there are reasons for that, especially when coming to where are the nerves situated in the arms. So if we miss those areas, then we might be injecting in the nerve. And we have seen common practices with especially with the COVID-19, where our nurses that were employed to assist, you find that the person have been trained long time ago, and they inject you, even us as nurses, when you get there, and then you look at the area where they are cleaning, then you get surprised to say, okay, this is actually not the correct site. So it's mostly about the site and the technique that you use. It has to be IMI at the correct site.
Thanks, Dr. Sophie. I think we can move to the next question. Thanks, Lesego.
Yes, we've got 2 more hands, and I think that will be it. Peladi, you may unmute your mic. Peladi Mokoka. Peladi, you may unmute your mic. All right, let's try Kikelomo. Kikelomo, you may unmute your mic. Kikelomo. All right, I think I saw Kutele. Do you want to make a comment or a question? Kutele, please unmute your mic. All right, we try one more and then we will close the heads. Franz, is your hand up? All right, Franz, giving you one more chance to unmute. All right, I think I will lower all the hands, and I'm not sure if we are ready to say our closing remarks and maybe close the session.
Sure. Thank you, Dr. Lesego. I just want to, I saw one hand going up now. I don't know if it's a new hand.
Just, no.
Okay.
Sorry about that.
The ghost, that's fine. Okay, so I just want to go to the presenters and panelists. So again, this is a reflection of all the presenters and panelists, the organizations that they work for, and their designation within those organizations. If you have any questions related to a specific section, please reference the training material and see who's the most relevant person to contact regarding your query. We have people from our different NGOs, and we would like to extend our thanks to all of our support partners and all of our colleagues at the National Department of Health for the development of the content and of the training material and of the implementation guide, which is available on the Knowledge Hub. As we said yesterday, the Knowledge Hub is a zero-based website. So either for attending training or for downloading any documents from the Knowledge Hub, there would be no data fees that would be charged. So it's a great platform to attend all of the trainings that is provided by the National Department of Health. And we'll give you access to up-to-date guidelines, and there's also CPD training available on the Knowledge Hub. So we would like to thank all our support partners, including CHI, the CSIR, the MRC, SAVIC, the SMU University, CHAPS, UNICEF, SCTA, the WHO, and the DG Murray Trust. And thank you very much for attending tonight. We much appreciate your continued support for the vaccination program, and good night.